Today we focus on how services might best respond to dependent benzo use and emerging practice in terms of prescribing. This issue is of crucial importance. Non-prescribed benzos have always been a significant factor in polydrug use in Scotland and sadly in overdose deaths, but this has escalated. So in 2008, benzos were implicated in about a quarter of drug overdose deaths in Scotland. A decade later, they're implicated in 2/3 or more of these deaths. Today, we'll have 4 presentations from Joe Schofield, Research Fellow at University of Stirling, Daniel Mogford, a consultant psychiatrist in Lothian, Trina Ritchie, lead clinician and senior medical officer with the Glasgow Alcohol and Drug Recovery Services, and lastly from Tracy Klusker, who's the newly appointed clinical lead for MAT standards with the Scottish Drug Deaths Taskforce. I'm delighted that Tracy will be sharing with us the voices and experiences of people with personal experience of problem benzo use, which is a crucial perspective, of course, that will help shape our discussions today. Then after the presentations, we'll have a question and answer session. You can submit questions at any time during the webinar using the questions tab in the control panel on the right-hand side of your screen. Kirsten Horsburgh, SDF Strategy Coordinator for Drug Death Prevention, will join us for the discussion and summarise the questions from people attending today, and we'll put them to the panel. We'll also share all the questions and comments with colleagues in the Drug Death Task Force after the webinar. So let's get started with our first presentation from Joe.
Thanks, Austin, and thanks to everyone for the invite and joining today. So I've got a few minutes to speak about some work we did at Stirling and with the Drugs Research Network, looking at the views of addiction prescribers on developments in management of benzodiazepine dependence. Next slide, please. We conducted a survey of prescribers that was keen to get their views on issues surrounding the care of people who are dependent and what kind of service developments and maybe new interventions we need to help support people. And I want to acknowledge Mike Turner and Shona Anderson from NHS Grampian, who conducted a preliminary survey in 2018 that we built on. So we had 55 respondents and a relatively good mix from across Scotland. In terms of where people worked, we had a lot of addiction psychiatrists who often prescribe benzos, nurses, and then some medics, and predominantly people worked in specialist addiction services with some based in GP and one person from a prison. So we asked people about the size and the type of their caseload to get an idea of the potential demand that we're talking about. In terms of the opiate using caseload, people had an average of 90 patients, but you can see that there was quite a wide range. Half the respondents had between 32 and 300 opiate using patients. We then asked them what proportion of the opiate using caseload first presented with benzo dependence, and the average was 20. But most people said between 10% and just over half the caseload presented dependent on opioids. Interestingly, then when we asked how many of the caseload are currently dependent on benzos, that was actually higher, suggesting that some people develop a benzo problem while engaged in opiate treatment. We asked about the proportion of the patients who are dependent on benzos who have issues with other problems. And again, on average, we found that about 80% of benzo using patients have problems with anxiety, 70% with sleep, 60% with trauma, 50% with depression, and 15% had issues with chronic pain. So in terms of addiction services, we know they monitor patients' use of drugs while in treatment, and we asked whether they're current monitoring arrangements can allow them to differentiate between patients who are using prescribable benzos, such as prescribed Valium, versus those that can't be prescribed and are only illicit, for example, etizolam. And the main thing to point out is just 8 of the 55 prescribers said their service could detect the kind of benzos people use. This is worth bearing in mind because if a survey is going to prescribe benzos for someone who's on opiate replacement therapy, it's really important that they can check whether they've been using just the prescribed benzo or potentially illicit street benzos in combination, given the risks associated with that. So we asked prescribers whether they currently prescribe benzos for people with opioid and benzo dependence, and just over 2/3 said they do. Among those who do currently prescribe, I was struck by the range of different guidelines people use, ranging from local health board guidance through to national guidance, including the Orange Guideline and some of the Royal Colleges. Some also referred to the Ashton Manual. So again, there's a real mix of guidance people use, and there may be slight differences and inconsistencies between those. Of the people who don't currently prescribe benzos in the addiction service, we asked if they'd be willing to in the future. And again, just under 2/3 of those said it's something they would be willing to consider. Among those who said no, the main reasons were there's no evidence for it, it doesn't work, the GP should prescribe that rather than the addiction prescriber, it causes problems and increases demand from other patients. And one person said it's a slippery slope, it doesn't work and it leads to an escalation of benzo use. So I think it's important moving forward that we understand some of the concerns around people who are reluctant to prescribe benzos in the addiction context. So looking now at those who would prescribe benzos to dependent patients in the future, 4 out of 5 of them would consider diazepam as a suitable benzo to prescribe. The half of them would start people off on a dose of 25 to 30 milligrams, but interesting to note, there is quite a significant number around that proportion. Some would start as low as 15, 20, others would consider starting at 35 to 40 mil. And we asked what treatment plans they thought were appropriate for patients. Just over half said they'd aim for reduction and cessation of benzo use in around 3 months. Just under half would consider maybe longer term maintenance. But in terms of the comments we received, that is an artificial distinction. Many said 12 weeks is too short. You need to consider longer prescribing, being more flexible in terms of patient needs and how they present. We shouldn't set patients up to fail. And some said we'd consider maybe 6 to 12 months, but very much guided by how the patient is coping and responding. So we asked about how they'd like to dispense benzos in the service. In general, for patients who are on opiate replacement therapy, methadone and buprenorphine, they'd prescribe for them to be dispensed the same as the ORT. So if a patient was on daily supervised, they'd go that route. For patients not currently taking methadone, buprenorphine, etc., the main response was they'd consider daily dispensing with takeaway doses. Again, I think the rationale is so people aren't being given a month's worth of benzos in advance, leading to greater risk of them overdosing or diverting them. So quite a large graph, but we asked what supports clinics currently and would like to be able to offer to patients who have a benzo problem. I'll start with the blue bar. These show how many people don't currently have an intervention but would like to offer it. And it's really interesting that the main ones reported were peer support, whether led by a healthcare professional and or people with lived experience. Pain management and sleep disorder interventions, some clinics don't currently have those and think they're important to offer, along with helping people manage issues of complex trauma. And then just looking at the bottom of the list, the ones with the highest green bars, which show where interventions and services are in place, most services are currently able to offer help with anxiety management, general psychological support, and relapse prevention and motivational interviewing. So we've got an indication of what we need to put in order to provide better support to people dependent on benzos. Final slide of my findings. Next is we asked prescribers, excuse me, to score components of a good benzo treatment service in 4 groups. So these are presented with the #1 response in each group highlighted. So in terms of benzo prescribing, daily dispensing and supervised consumption came out tops. The principles of any benzo prescribing, the most commonly scored one was that evidence of illicit benzo use should normally lead to reviewing and stopping the prescription given the risks. In terms of patient adherence, again, the theme of daily supervised benzos and opiate replacement therapy for the duration of the prescribing, keeping people in contact with dispensing services who can check how they're doing and ensure safe dispensing. And then for psychological support, having support groups, clinician-led, were highlighted as being important, and also very highly scored was the routine use of validated assessment tools. So again, there's an appetite among prescribers for more consistency in the way that they understand people's benzo addiction use and how they're responding to treatment. So in conclusion, as I think many of you know, benzo dependence is very common among patients in addiction services. 2/3 of people who participated in the survey currently prescribe benzos in this context. Prescribing is informed by a number of different guidelines, which may lead to differences in local approaches. 82% of prescribers would consider prescribing to patients in the future, but of concern, a small minority are able to check whether people prescribe benzos are also using illicit street drugs on top. Addiction services have highlighted the need for peer support and help with some of the main conditions that may cause people to use benzos, and that kind of peer support and daily supervised consumption were key components reported. And then finally, please, in terms of acknowledgements, I want to thank the members of the study team, the networks of addiction professionals who circulated the survey to the members, especially to members of recovery communities who informed development of this project, and everyone who participated. Thank you.
Well, thank you, Joe. That's an excellent overview of the background and the context we're working in terms of practice and attitudes and beliefs of prescribers and potential prescribers. So thank you for that. So we're now joined by Danny Mogford from NHS Lothian. Thank you.
Thanks, Austin, and thanks for asking me to speak. It's always a pleasure. And when I was asked if I wanted to take part, I said that I would provide a clinician's view, and I think, to be upfront, that's a fairly conflicted view. I'm one of the people who provided a response to Joe's survey, and I guess it's worth acknowledging that my voice is one amongst many. And I guess the views that I'm going to present are ones that I've developed over my own practice, and there's going to be people who disagree with me on one side or the other. I think Joe has given a clear message that the evidence around prescribing interventions for benzodiazepines is pretty thin on the ground, and where it does exist, it's conflicted and it's quite confounded, and that leaves clinicians to navigate whatever evidence there is based on anecdotal experience or local clinical culture and local clinical guidelines. And for me, I guess the two best extremes of the evidence base are, we have a long-term case note reviews that assert that patients who are prescribed benzodiazepine maintenance have better retention in treatment and lower drug deaths. But then on the other hand, we have also very good and robust studies which actually say co-prescribing benzodiazepines alongside opiates leads to an increase in all causes of mortality and drug-related poisonings. So we're kind of left to navigate these two poles of evidence. I guess, though, on a day-to-day basis, we need to keep treating patients. We have patients coming through the doors all the time. We have large caseloads, and we know that more and more deaths are flagged with illicit benzodiazepines being a contributor. Austin mentioned that over a decade, that's gone from about a quarter to 2/3. And I think personally standing back as an addiction psychiatrist and saying, I don't do benzodiazepines, doesn't feel comfortable to me. I think we take in our daily work a really nuanced approach to juggling lots of competing needs of our patients, whether they be short-term needs, medium-term needs, or trying to think about long-term recovery. We are constantly thinking about how we enhance engagement, even if we're not necessarily doing it in the moment. We are always keeping an eye on how we facilitate psychosocial recovery and manage people's complex mental health concerns. I think as clinicians, if we're sophisticated to do all of that, we should be sophisticated enough to take an individual approach to how we manage problems with benzodiazepines. Locally, we do have some guidelines around prescribing, and I think they're extremely useful. In general, maintenance prescribing is seen as an intervention of last resort, but they do give the go-ahead for strictly boundaried community detoxes where other interventions failed. And certainly that's what I tend to use as support for what I do clinically. Joe, when he was talking about the burden of mental health problems in our caseloads, I think it would be not come as a surprise to anyone that we treat a population that has really high levels of trauma. We know that ultimately psychosocial approaches are what's needed in the long term. But I often see our role as trying to help patients find enough stability to engage meaningfully with these interventions. If benzodiazepines are part of this, I think we have to be very careful. They're a two-edged sword. We know that they will potentially interfere with the new learning that's required for lots of these interventions. But on the other hand, we need to keep people engaged long enough and frankly alive long enough for them to benefit from these things. So, I mean, from a personal perspective, I do a bit of everything. I spend a lot of time saying no to prescribing benzodiazepines. I do some community detoxes. The truth is they tend to be protracted and have a wide range of outcomes. I do a bit of legacy maintenance prescribing, and I also do a bit of new maintenance prescribing, and that tends to be in situations where we've not even been able to stabilise somebody on a prescription of OST because the handfuls of Xanax or Atizolam are such a barrier to simply getting to the pharmacy in any consistent way. And although it's not risk-free in those situations, I'm sometimes up for providing a prescription that helps to rein in some of that chaos. I think I would be remiss if I didn't step back and maybe talk a little bit very briefly about the wider context, and that's that as it stands, we're all operating in an environment that's incredibly thinly stretched. We know that we probably have less than half of the people in treatment with our services who should be in treatment with us, and even reaching a fraction of the population we need to attract, we don't have sufficiently resourced or connected services to provide the full range of recovery needs that we know our patients need. And all of these are required if we're going to address what I see as an epidemic of polysubstance use and deaths. I think we have to be aware that what we do as clinicians is a small part of a society that has many people feeling marginalised, not able to access housing, not able to access meaningful occupation. And I think it's really important that in that context, benzodiazepine prescribing is a very small part of the picture, but it is an important one. So that's my conflicted view of prescribing.
Thanks very much, Danny. We'll now hear from Trina Ritchie from the services in Glasgow.
Hi, I'm Trina Ritchie, lead clinician and senior medical officer in alcohol and drug services in Greater Glasgow and Clyde. Delighted to be invited to contribute to the session today. As previous speakers outlined last week, we're in unprecedented times with regard to harms from street benzos. Today, Joe described the varying prescribing practice and attitudes across Scotland and even within single services, and Danny very eloquently detailed the challenges of the conflicted clinician. When considering my 10 minutes of fame today, I was wary of repetition, so I've chosen to focus on sharing some very practical aspects of benzodiazepine prescribing practice in Glasgow. I only have a handful of slides. I don't really need them, but I realised if I didn't talk to slides, my face would be front and centre of all your screens. I'm a bit more shy than Danny. A couple of years ago in Greater Glasgow and Clyde, as part of our response to increasing drug deaths and harms, we agreed local benzo prescribing guidelines, particularly for people on OST who may benefit from benzo prescribing because of perceived harms. They outline a pragmatic approach to try to provide a framework to support clinical decisions, as Danny referred to, and also support care plans, despite the lack of available evidence. In addition to the lack of standardised prescribing practice previously described, the other context for the development of the guideline was observation of particular difficulties achieving a shared language around benzo interventions and a lack of documented clarity of reasons for prescribing or not prescribing. In particular, our experience was of staff and service users referring to the need for a benzo detox as an intervention for high-level chaotic benzo use. But in practice, short detoxes, whether community or inpatient, were infrequently useful. So we tried to categorise benzodiazepine prescribing indications, noting they're largely off-label and not including alcohol care and treatment. And we encourage people to try to align their prescribing and decisions if they are prescribers, or their assessment and care planning if they're key workers. In indication 1, although continuation of an existing prescription seems a no-brainer, it doesn't always happen, and people describe developing difficulties with street benzos due to interruption of previous prescribing. So I think it's important to recognise continuation of long-term prescribing in its own right. Original indications for prescribing may often be unclear, and a refreshed benzo care plan will likely be required. Indication 2 notes the category of therapeutic benzo prescribing for mental health reasons. And you'll see we still have detox in there at indication 3. However, the detail in the guidance goes on to describe individuals who require detox as being established in their recovery and only requiring brief low-dose detox to move from small quantities of street benzo use to abstinence. Indication 4, prescribing as a harm reduction intervention, is really the one I think that's of relevance to today's session. Stabilising chaotic high-dose benzo use that is causing harm and is continuing despite optimisation of other treatments, or is precluding delivery of appropriate treatments. Looking at the detail of considering a harm reduction prescription, the quality of assessment is crucial. I think unfortunately sometimes we've become almost desensitised to reported street benzo use, recording things like using 20 street tablets a day and moving on without listening to more detail. But we really need a detailed picture, numbers and types of tablets, patterns of use, varying effects. What happens if people reduce or stop? Not just generalised statements, but as I say, a very detailed picture. So for example, someone reporting that they buy 50 tablets at a time and usually take 8 in the morning and 8 or 10 at night. Different tablets have different effects, saying sometimes I feel almost nothing, but sometimes I lose a day. If I stop taking them, I actually feel okay the next day and get sleep that night. But the day after, from about lunchtime, I have really bad panic and sweating and a racing heartbeat. That sort of level of detail. Quantifying harm related to benzodiazepine use. This requires widening out the assessment, obviously, to describe the associated harms for that individual. The risk-taking behaviours, non-fatal overdoses, falls, assaults, exploitation, relationship, mental health problems, criminal justice issues, homelessness. From the consultations and also possibly from corroborative accounts, clinical systems, etc. Identifying shared aims. This, I think, is where things can become a bit tricky. If someone's in a place where they're experiencing harm from street benzos, but at this particular time, they want to continue to use large quantities of benzos, considering adding in another source of benzos can be quite difficult to rationalise, despite acknowledging significant harms. So we're really looking for a shared aim of reducing or stopping street benzo use. And I think this is tricky as well because it's at odds with OST, where we would still start someone in treatment if they're aiming to continue opiate use. Agreeing progress plans. A detailed picture of harm prior to prescribing intervention informs what would be considered harm reduction for that individual. My view is total abstinence from street benzos a necessary goal? And that view also is in the context of the question, are we reliably able to monitor street benzo use? Before making a decision about prescribing, there should be a candid discussion of what will happen in a range of scenarios. A prescribing intervention could potentially increase harm could stay the same, or harm could reduce. As with OST, we should balance positive progress with a period of maintenance rather than feeling that we immediately need to move towards dose reductions. And before we start any prescribing intervention, there should be a shared understanding that if harm increases following the prescribing intervention, it may potentially stop. If someone's also an OST, there should be a plan for completion of the benzo harm reduction intervention prior to any OST detox. And as already mentioned, the same tools would be used as in other alcohol and drug interventions, drug diaries, decisional balances, anxiety worksheets, recovery workbooks. An informed consent to treatment, including for off-label indication, is important. Since the Montgomery ruling, we've recommended an active informed consent process. This is a little bit of feedback from a couple of people who've recently been commenced on diazepam prescriptions with the aim of reducing harm. They've reduced their street drug use, and they're now moving forward with trauma-focused care plans. You can see the feedback is overwhelmingly positive, and this has largely been my experience as a prescriber. Interestingly, implementation of our local guideline has been a bit challenging. Despite existing for some time, it hasn't really had the expected impact on practice, and it seems prescribers have largely remained either pro or against prescribing. There were plans to relaunch the guideline, which unfortunately have been delayed by the pandemic and are only now progressing. These are my contact details. Thanks for your attention.
Thanks, Gina. That's fantastic. Thanks. And our last speaker is Tracy.
So I'm going to really follows in nicely from what Danny, Trina and Joe have presented so far. So my presentation is more looking at benzodiazepine prescribing in the context of the medically assisted treatment standards, which is a work stream of the Scottish Drug Taskforce. But rather than looking primarily at prescribing, I really wanted to look at case studies of people who are living with this and their experience of being prescribed diazepam or when they have, and the impact that it's had on their lives, as well as really putting together a trauma lens. So I want to see it more from the reasons behind why people are using benzodiazepines, as opposed to just looking at whether prescribing is the correct pathway or not. So it's just really to get people thinking behind the really difficult decisions and the conflicting decisions that people are making within services on a day-to-day basis. So I'm not going to go through all the MAT standards, but one of the work streams that I'm working on within the Scottish Drug Taskforce is the implementation of medically assisted treatment standards. And this is a set of standards that we are consultant with the agencies, a lived experience reference group, ADPs, and the workforce, as well as families affected by drugs and alcohol, really to look at having a more consistent way of working with people. Now, I won't go through all the standards because we don't have time today, but hopefully that will be in a follow-up webinar. But really the ethos of the standards really is around realistic medicine, which is the same for anyone accessing healthcare or social care within Scotland today, is that people are at the centre of all the decisions that are made about them, that they have choice. Now, within the standards, we're looking at people having rapid access to OST. Now, we know that many people who use OST are using benzodiazepines, so we have to think about the context of where benzos fit in when we are looking at the delivery of rapid access to OST, and how we treat people who are equally dependent on benzodiazepines. The ethos of the standards is around choice, right to advocacy, housing, welfare, and really reducing harm and seeking people who are at harm. And we also have a younger population of people who may be using many novel benzodiazepines, who primarily may not be using opiates also. So within all of the MAT standards, I suppose today I'm thinking about how we go ahead and deliver these standards and implement them, considering through a trauma lens throughout all the standards for the people who are using benzos. Now, this is a priority, as Joe said, for the task force, because benzos have been implicated in 792 deaths in 2018, and a huge percentage of people, as I say, presenting for OST are using benzos, and that can be, we're certainly seeing an increase in coding for benzodiazepines and near fatal overdoses. So when I was asked to present, I thought it was really important to get the voice of people who are, as I say, living with benzodiazepine dependencies today in Scotland. So I had spoken with Justina Murray from SFAD, and they had, when you're looking at how services are delivering, had a really good campaign that certainly I was involved with a family member around behind the numbers. So I thought it'd be quite good to look behind these numbers of all these people we are talking about who are dependent today on various substances, including benzos. So I was lucky enough, with the help of a person with lived experience, to interview people from across Scotland. Now, we have done voiceovers to keep people's anonymous for their own, because they were kind enough to share these aspects of their life. And I really would just like people to hear the perception of the people who are using services. The first gentleman talks about the benefits. Now, he's less focused on, that I've stopped using benzodiazepines. He talks about relationships. He talks about having a normal life, having carpets, have access to Wi-Fi, seeing his family again. So I think when we're talking about measuring success of whether an intervention has been successful, is it really around whether somebody stops using all illicit benzos, or is it that holistic impact in all aspects of their life? He also touches on that it did help him. It was protective in terms of retaining him in treatment. So he was also on OST, but being on OST and a benzodiazepine prescribing regime did allow him to maintain his treatment and attend the pharmacy. The second gentleman talks about having a non-negotiable detox when a prescriber changed, and the impact was really traumatic for him. He was a man who has a history of complex trauma. and he, you know, for him, he feels having a non-negotiable detox with somebody doing something to him again in his life, and he talks about, you know, and it feels for him that he felt the risks were increased when he was taken off a benzodiazepine prescription. As that person talks about, he's now in long-term recovery over 10 years, and benzo prescribing was a huge part of that, and he touches a bit about on why the reasons he came into using benzos in his life. So we'll play the recordings.
I mean, before I was on diazepam, I couldn't be bothered getting off my button to go to the job centre and get the right amount of money. Now that I am on them, I'm on PIP, I've got my universal credit put up, I'm living in a house, we bought a washing machine last month, we're getting carpets and that this month, getting what is it? We're getting, what do you call it? Wireless today, Wi-Fi today. So just getting on with life like a normal person. I would have never done that with those tablets. My nana is more than happy for me because, like, as you know, I've really only got my nana and my granddad left close to me. My nana is as happy as could be with what I get prescribed. She just doesn't like anything else on top of it, same as me, which I try to not do. I'm not an angel, right, but I try. They would put me straight into a panic attack and probably into a rage as well, because I would be thinking about what I was going to have to be going through, and the fact that I would have to be going and trying to buy things off the street and that, which that doctor would know could kill me. Why are you taking my normal tablets off me, which you know are alright for me? Because I've signed a waiver saying, like, if it affects my memory, the pros outweigh the cons to me, and I'm sure to a lot of people that's the same thing.
See, when I had my meth and Valium, I was able to, I did function a lot better, definitely get things sorted. Like even letters and that, simple things, ken what I mean? Be able to get all that done. It's just, I don't know, it's just totally different. They should never have taken folk off them, especially folks like that, and then leaving them with no option but just to chase whatever's out there. I'm trying right now with the doctor. She's asked me to do a wee diary with numbers. I've done all that. I'm still waiting to get a phone call from her, 6th October, I think it is. I gave her a drug sample. I've done that, 10 days groups, getting into groups, getting myself down to 30 milligrams, taking them, but not all at once, taking them in the morning and at night, again, instead of taking them all at once. No, it's not all that easy, no. Because there were 5s, there were 2s, I was just taking anything with Valium. I've been addicted to them since, I don't know when, since a very early age, right? And so, actually I'm 40 now, so that's like 30 years I've been addicted to them. So I've got an addiction and it's taken them, you know what I mean? I come off of them, aye. Just being stable in my meth, and then I'd never detox right now because I'm not concentrating on trying to be out and getting weaned off of them. Right, slowly. We talked about it with the doctor, Ken, know what I mean?
So I started using benzos. It was my first substance that I started using when I was 16 years old. My my family had just broken down, and there was so much had happened. We ended up homeless, and I was looking after my granny. She had dementia as well, you know, so I went through a stable sort of home life to having nothing. So once I started taking benzos, it just took everything away. It stopped me thinking about things, it stopped me feeling. And I also I continued to use them for over 16 years, you know, to the point where that was always sort of my drug of choice when I look back and think about it, because it done what it said on the tin. I realised now that I had anxiety back then, but I didn't know what it was, and the benzos took that away. There was so many myths going around. I got told that you couldn't overdose on Valium. I would take as many or as little Valium as I could get my hands on. I was buying tubs of 10,000 for people. I was selling Valium, I was selling other substances and stuff like that. To the point where, you know, I probably did overdose a few times as well on alcohol and cocaine and all other polydrug use, you know. I didn't know what it was at the time. You know, even though I was in deep in the substance circle, I was pretty naive to things, you know. And for me, I think once I started, there was so much trauma happening, you know, and so many losses, and it was just that lifestyle I was living that it just built and built up, you know.
So next slide. So I guess that takes us on from the last person who'd spoken with me really about the reasons why, and I think this is a really important point to make when we're thinking about starting to work with anybody, is that adversity is not destiny. You know, we have to start at a point to get alongside people, and rather than, I think we often, you know, and I did take a bit of time actually speaking when we were looking at what's happened to you and what's wrong with me, to Isabel Trainer and Claire Campbell from the LPAS team. We were chatting about, you know, how we could work with people more creatively to engage people who are abusing any substances, really, but benzodiazepines in particular. And we talked a bit about we tend to pathologise it when we actually know a high proportion of people, and the people certainly I met with who talked about their substance use was that, you know, it had a function, it worked very well to help, you know, soothe trauma. As service providers, we know that a high proportion of people we see do have a history or would meet the criteria for PTSD and complex trauma. So we talked about a formulation of a person's own difficulties when we are working alongside people who have got trauma, and working with them where they're at, and base the approach around what people can deal with, and that acknowledgement that engagement can be very difficult for people, and an acceptance of the barriers that some people find engaging with services, and some of the things like someone I spoke to talked about drug diaries being very difficult when they are using so many substances and being unable to manage that, trying to work with people in a trauma-based way that allows them to have some control over what's happening to them. I'm going to move on. I met with a family member who, and I will try and finish up quickly, Austin, who had kindly spoken with me about her son's history. He would meet the criteria for PTSD, complex trauma, a young gentleman with multiple adverse events who unfortunately has been using benzodiazepines for over 10 years. And this woman herself has put her career at risk trying to support him. His engagement with services is difficult through his own trauma, and they kindly said that I could share a poem that they'd written, just really that in their own words what it feels like to engage with a service when you're using substances. So I'll just read that out and then I'll conclude. So this is through the eyes of an anonymous person, aged 22. Mum, one of my first memories was the smell of your tears. I remember I grew up in a house of sharp-edged silence. Gangs gave me what your dad couldn't give me, respect, while the police threatened with fear. The feeling from the pills is also sweet. People just don't take drugs the way or why services think that they do, and I never thought society would forgive me. So I thought that was quite a powerful poem, and I thank that family for sharing that. So what can be done? So if we know that there's not a great deal of evidence around benzodiazepine prescribing and whether it reduces harm, there'd be some thoughts that it could increase harm. But what we need to do is try and look at what we can do. We know there's many people who have benefited from it. There's many people who continue to use. And from a task force level, it'd be quite good to look at getting together a subgroup of interested people and start where we can with what we do have. We've got agencies who are managing to prescribe some of the work that Glasgow have done with Trina, some of the comments that Danny had said, and Joe, and the family members, they could be seen as harm reductionists to work alongside us with their family member, and we need to work with people and their families and communities together alongside services, and hopefully we'll create some sort of subgroup to look at how we are working just now, how we can improve that. I think we have to share what we're doing across Scotland. We have evidence of good practice and learn from each other, and ensure that through every part of the service delivery that we are trauma informed and we think about that compassionate response to people who are approaching services who do have adverse events and find some of it difficult to navigate. And I'll just finish when I asked another family member what she thought we could be doing in terms of what can be done around benzos, and her comments were challenging yet possible if we are prepared to listen harder and be in a place of empathy rather than judgment. So that's me. I want to thank all the people who shared their life stories with me. Thank you.
And thank you, Teresa. That was excellent. Thank you. Could all the other panelists join us, and we'll be joined by my colleague Kirsten, who has been fielding the questions. Okay, Kirsten, what's happening out there in the land of silence?
I'm scribbling away frantically, trying to try and coordinate some of these questions. So thanks very much to everybody who has been putting questions and comments in the sidebar there. We definitely won't get through all of them, but I'll try my best to consolidate some of them. I wanted to first start just because it was specifically things that were related to the video that Tracy showed with comments from Tony and John, and those questions were in relation to what impact do you think the move away from benzo prescribing has had. I specifically remember that time myself, and certainly worked in services when people were being refused access to OST if their drug screening was coming back positive for benzos, and then the time where we moved from prescribing 10mg tablets to 2mg tablets, and then no prescribing at all. So what impact do we think that has had? And also link it to some comments that Tony made regarding having to sign a disclaimer regarding his memory. What are the issues from long-term prescribing and any side effects in relation to harms or mental health? Thank you. Sorry, that's a lot.
Well, I suppose that's potentially a question for everybody, but maybe we should start with Tracy.
Okay, thank you. I actually worked in services when that did come around, and there is evidence that long-term prescribing can cause irreparable cognitive function, which actually a great deal of people you work with are aware of. And there was a move to less, certainly when I first came into service 15 years ago, most people were, or a high portion of people were prescribed benzos as part of normal prescribing with less focus on detox. And then there was a huge shift. I suppose some of my concerns are if someone is with a prescriber and and one of the case studies he was doing very well, and then they just move straight from, a different prescriber comes with a different sort of threshold for their own prescribing, which is understandable, but for the person and the impact for the person who has been prescribed for some time can be catastrophic. So it's being mindful of that. I think people that you work with would say that it's had a negative impact. However, we now have people on the internet, and there's this huge supply that probably 15 years ago we wouldn't have had of illicit benzodiazepines that it feels that we don't seem to have a great handle on amongst street drugs. People are, there's they're buying, you know, from the internet. People can get them. It's very, very easy to and very cheap apparently to buy illicit benzos, which would be a slightly different illicit market from what I can tell. I don't know if anyone else wants to comment on that.
Gina, and from the point of view of prescribing practice, if you hang around prescribing long enough, you learn to see these cycles come round, I suppose, in terms of what's regarded as good practice or what we should be doing. And are we at the point of a turn? Do you remember the last time when this was made more difficult?
Yeah, I do remember, and all those sort of community step downs and all the reducing and stopping prescribing. I think in terms of Kirsten's earlier question about, you know, that somebody had asked about the impact, I think certainly, you know, there will have been an effect from that period. Possibly positive for some people who will have done community step downs and moved away from a benzo prescription. But again, as I was talking about earlier, people who then ran into problems with street benzos. But I suspect that impact pales into insignificance with the size of the benzo problem now, and that it's the availability, you know, a much wider availability that's the issue. And I don't think we're near a turn yet, Austin, however much we might. You know, I think, as we've all said, that we're struggling to show an evidence base. We're looking at tests of change and changes in practice, but I'd be very surprised if we're at a turn in prescribing. And I suppose we saw that over the last couple of years with the guideline in Glasgow, that it's been embraced in terms of practice by some people, but it hasn't changed many people's practice.
And Danny, it does prescribers' beliefs, you know, people who say I'm against this, does that simply reflect old guidance or things that were around a few years ago and just people hold on to those beliefs?
I think it's a tricky one. I mean, I think none of us want to do any harm, and we're talking about an area where it's hard to know if we're doing the right thing or not. And I think, you know, there are lots of downsides to prescribing. You know, Tracy's talked about the memory impairment, and we know that's true. You know, we know if we're trying to treat people who have got significant anxiety disorders, a benzodiazepine prescription in the long term may actually make things worse, may make it harder to deliver the treatments that, you know, the evidence would say have the best long-term chance of success. And I guess it's worth, in my mind, separating out when we're talking about harms of prescribed benzodiazepines and harms of illicit benzodiazepines, because the reality is we're not talking about someone taking 5 milligrams of diazepam 3 times a day that was diverted from a pharmacy. We're talking about people taking handfuls of high potency benzodiazepines that are not licensed for use in the country and are having all sorts of pretty disastrous effects. And so I don't know, I realize I'm kind of hedging a bet both ways, but it's complicated. And I don't begrudge anyone who says I don't prescribe benzos, because I think they're doing that from a position of not wanting to cause harm. And, you know, maybe they have an easier day. You know, I have lots of frustrating conversations with patients telling me that they were talking to their pal who I prescribed whatever to, and why won't you give it to me? And it's a difficult conversation to have. You know, it's hard to communicate. I'm trying to do the best thing on an individualized basis. Yeah.
Yeah, these are the dilemmas of prescribing. And have you any comment on that, Joe? Did you pick any of that up in your own survey?
I think I'm really struck by what Danny and Trina said about guidance and evidence. And obviously, as a non-clinician, it seems to me there's a lot of historical evidence in the literature and in clinical guidance around the harms of taking benzos while on opiate replacement therapy. And Danny's just highlighted some of those harms to patients. And it feels like in Scotland, in the context of a drug deaths crisis, it's about weighing up the harms of prescribing a known substance of a known potency under conditions of giving someone a lot of support, versus the harm of them going and self-medicating with, and we all know the risks associated with street drugs. So I don't envy the clinicians trying to keep themselves and the patients right. And just finally, as a wee plug, myself, Danny and Trina are involved in a project funded by the Scottish Government Taskforce that is looking at evidence in Scotland of what are the outcomes for people who are in addiction treatment, who are prescribed benzos, and are they at more or less risk of harm. And it just feels weird to be in a position where we're now trying to pull that evidence together from historical data, and there does seem to be a dearth of it and conflicting viewpoints. So I don't envy the clinicians or the patients trying to navigate this.
Well, thanks for that, Joe. Kirsten, have you filtered another question?
Underestimate how difficult it is to listen and read and do at the same time, but I'm trying to work out what's not been answered. So there's obviously a lot of support in the comments and the questions for benzo prescribing. That's clearly coming through, and the need for it, particularly so that it doesn't cause problems for people who are prescribed medication-assisted treatment, so opiate substitution therapy, because is that setting up people for failure if we're not also prescribing for benzo use and we're only addressing the opiate use? But also, how can we reach people who are not attending for opiate-based substitution therapies, and how can we provide interventions to groups of people who may just be using street benzos?
Yeah, Tracy, you mentioned that group of people who were primarily benzo users involved in polydrug use, as people are, but weren't using opiates, but were using benzos.
Certainly. We have seen it in our service, especially with MyPass, which is a young people's service. They're seen more and more, and through our homeless hostels, and this is just very recent, we're seeing more and more people coming through who actually have, many who have been through sort of looked after children, and they're very like teenagers really, young adults, or they most certainly all have some adverse events and or complex trauma, and they seem to be using a lot of benzodiazepines, but very harmfully. And some people are coming up coded as overdoses we're even seeing it in some of the ambulance data now. It'll say benzodiazepine overdose, but it's actually young people, and it's actually benzos that are and alcohol that are the primary issue, but there isn't any opiates there. So certainly we need to start thinking about how we work with people who are, they won't come traditionally through an opiate. They're not going to be coming looking just for medically assisted treatment. So I think when we're looking at the MAT implementation, we have to be mindful that there is other people that are at huge risk of harm, who require that wraparound support Joe was talking about. It's not just the prescribing, who may not be part of any service. So it may come up through the hostels or through other young people's services, certainly. And I think when we're thinking about a set of outreach projects, we have to think about this group as well as people who've been using drugs or maybe known to services for longer. Certainly an emerging issue, I think, just with, and it's not just benzos, I think there's some issues with ketamine and other drugs, but certainly benzodiazepines are featured in younger cohorts.
Yeah, and there's always that kind of mysterious but suspected link with minimum unit pricing and as you were saying, the just availability of substances and routes of supply and so on. Trina or Danny, are you coming across people whose primary problem is around their benzo use?
I think they do come our way. I was going to say, I think particularly when we're talking about young people, I think it's important not to get too narrow in your focus and think that prescribing is the only intervention. We spend a lot of time when we're dealing with alcohol sort of trying to explain that the detox from alcohol is this much of a much larger treatment plan. I think we have to be careful, particularly with isolated benzodiazepine use, that we don't just think a prescription is the fix, because actually it's really important, as Tracy was saying, around the wraparound support, and that prescribing isn't necessarily a first line intervention, particularly with a young person. But yeah, we do. I think a lot of our isolated benzodiazepine users probably end up doing quite well away from NHS-based services, so they will often be seen by our partners in the third sector, but with some support from us. But again, as Tracy alluded to, we do have the occasional one that is more complicated, and it's often more than just benzos. It might not be opiates, but it's things like ketamine or other substances as well.
Gina?
Just really very similar, I think, in terms of, yes, we do have people who are not only treated within our purchase services, but who come to us. I think being tactful, it's an area of service development probably, in being able to attract and get some traction with some people who would benefit from some time within the service. And I know it's a bit of an elephant in the room. I've mentioned it once, and Danny's mentioned being stretched, but we haven't really talked about this in the context of the current situation. But, you know, again, it's a piece of work that we were looking to develop around people who report benzodiazepines being their main issue, or other sedatives, gabapentinoids, GHB, and things have been put on hold at the moment, or not really been able to be progressed because of the pandemic. So,
and I mean, again, not to be too cheeky, and it's not just the pandemic. You know, our services are massively resource constrained, and I think, you know, that's not me being critical, but I think it's important that we say it, and we say it frequently. You know, we're stretched thin. We will always try and do the best we can, and we're always looking for other populations that we should be helping. But there are only so many of us, and we only have so much at our fingertips. But yeah, and the pandemic's made it worse.
Yeah, sorry, just come in again there after Danny, and very much what Danny's saying. I think there also is an anxiety within specialist services that if you say too loudly that you've got a really good intervention for, you know, to support people with problems with benzodiazepines, that you may be very easily overwhelmed. So that does affect services and how they engage, I think, as well.
Yeah, and share innovation or even ideas. Yeah. Joe?
I just wanted to ask the nurses and the doctors involved. I know all patients are different, but if you've got patients who you're prescribing ORT to, how much does it add to the complexity of the management and the demands on the service when you add in benzo prescribing?
I think the truth is, Joe, probably for the patients who we would be considering that, it's often patients who have fairly significant needs anyway, to be honest, and it probably becomes part of a much larger care plan. I think, you know, you alluded to it briefly, and it's a small thing. I think one of the privileges that I have working in Lothian is that we have a spectacular lab that breaks down our benzodiazepine testing, and so we actually are able to differentiate between prescribed and illicit. And so I guess a lot of what I'm saying is in that context, and so actually, you know, it's easier and it is a lower workload to think a little bit more broadly about what interventions we can offer, because we can monitor it pretty closely.
Thanks for that. Kirsten?
Yes. So
if it's any guide to you, we probably have time for 1.5 questions.
I mean, don't put the pressure on me to choose one that I think is the most important. They're all very important. I guess there are some, and it probably has been discussed already in some of the conversation as well, but just about that side of, you know, clearly drug death, we can't deny the implication of benzos in the rising numbers of drug deaths that we're seeing, and certainly we would expect the drug deaths that will be reported on in December for 2019 to reflect the fact that benzos again were implicated in a large number of deaths. So if this is to be the last question that we get some discussion on, what does success or progress look like going forward, and how can we get there?
Okay, I'm going to open that up for whoever wants to answer it first, but I'll say that I'm going to ask each of you to answer it. So, how do we measure progress?
Yeah, I don't know. Are we talking about more broadly on looking at services or a national level, or are we talking about for individuals? Because I think, ultimately I have 620 something individuals who, by some means, I'm responsible for. And for me, a good outcome is that it sounds trite, but they're living a life that is meaningful and positive for them. And I'm not going to set a line in the sand and say what that is. I think it's really important that our patients are able to identify what they want. And I don't mean I want the following prescription medications, but I mean what I want from life. And I will do what I can to try and help someone get there. And to me, that's success. And I would like to think that on a service level, success is having the flexibility, having the time, having the tools at our disposal to try and deliver that in a way that's nuanced and meaningful for the patient who's in front of us. Sorry, I know that's a platitude, but I think that's the best answer I've got.
Oh, thanks, Danny. Tracy?
I suppose it is a bit, is it the individual? I suppose it is, I think success is when we are working in that way, that we're alongside people and they've got some control, or they feel that treatment isn't just done to them, that people have got control, and that as services we're working shoulder to shoulder with people. And I do think one shoe's never going to fit all, so I don't think we'll ever maybe get to a point that we're going to have one set of governance tools that are perfect, because I think the complexity is, it's so complex, the issue. But I think if we are working and we've got the resources even to do that wraparound care alongside prescribing, if that's deemed to reduce harm, I think we'll, because I think we do have to, it's not just about us saying, yes, we'll just prescribe for everybody, it's making sure we've got the ability to work in that psychologically informed way and work with people where they're at and their families to hopefully reduce harm. And that might be that someone, I think we need to have routes coming in, so that if someone is chaotically using, how do they get to the point of a reduction in harm if our services aren't able to attract people to come in the first place? So I think we need to continue to work and see what fits around the person rather than people always fitting around services.
Thanks. And Trina, have you anything to add?
I don't think I've got anything to add to what Danny and Tracy have said already, except I think it's very important, the point that Danny made around resources, that some of the things that I was talking about the detail that's required for a meaningful intervention is impossible if you're overwhelmed, as a frontline worker. And, simple things like being special services being protected from the savings agenda each year would be very helpful. So, I think resources would enable us to move towards success, whether that's for the individual or on a wider, more strategic level.
Thanks. I think we have time for one very quick question.
Me off guard. There are quite a few questions about how we can utilise other services in relation to providing additional support, so not necessarily the prescribing services. So I don't know if there are any thoughts on looking at that whole workforce in general, and where we think that support staff working on the ground can also contribute to assisting people in relation to their benzo use, and not just the prescribing side.
Okay. Did that come up? Did your survey cover that, Joe? Was there any insight there?
Yeah, I was really struck by the most commonly reported interventions that services wanted to provide were around peer support, and that being led by clinicians, pharmacists, and or peers. And I think it's really important that that's not seen as a cheap alternative to clinical care. And it's not just about signposting people, leave my service and go and try and access this one, but about more around that kind of integration of, you'll receive this one-to-one support from this nurse, doctor, pharmacist, and within the context of that care, here is some more talking cure person support that you can get from support groups. So yeah, that the prescribers were calling out for that.
Yeah, and we really do have 1 minute. So is there anything burning to say in terms of the non-prescribing support?
No, I can just say Glasgow's in a very privileged position to have an enormous range of supports available. So I feel that I can't just say that we're able to take advantage of those. Yeah.
Okay. Well, I'm afraid we're going to have to leave it there. It just leaves me with my concluding remarks, which are just to thank everybody, of course, and to remind people that this webinar has been recorded and will be published in the SDF YouTube channel as soon as possible next week. And an evaluation will be emailed to everybody shortly, and it'd be helpful if everybody could complete that. We use all that information, and it'll be useful to the task force too. And I want to thank everybody for attending, and of course to today's speakers to say thank you for what's been a very interesting and informative session. So goodbye and thank you.
Thank you.
Thank you.